In this video, I'm going to discuss different heart murmurs and then provide you with clues on how to distinguish different heart murmurs on the exam, discuss the phenomenon of normal splitting seen with the S2 heart sounds, and then discuss the anatomical heart defects that are associated with wide splitting, paradoxical splitting, as well as fixed splitting, and then finally discuss the expected blood pressure in different chambers of the heart, and then go over the memory aid that I've provided you here to help you with its memorization. So starting with different heart murmurs, usually you should know that the information in the question can help you with distinguishing the type of heart murmur that you're dealing with. For instance, if they give you a scenario where there's an elderly patient that passes out during exertion, like for instance when the patient was climbing the stairs, then that should give you clues to the diagnosis of aortic stenosis. On the other hand, if in the question stem you see that there is a wide pulse pressure, let's say for instance that the systolic blood pressure is 170 while the diastolic blood pressure is 60, then that should give you clues to aortic regurgitation. So what I'm saying here is that usually the information in the question give you clues on the type of heart murmur you're dealing with. But then if you want to exactly pinpoint the murmur that you're dealing with, there are two important facts you have to be familiar with. One, the location of the murmur. In which of these 4 points is the murmur loudest? And then finally, whether the murmur is diastolic or systolic. Now, with the location of the murmurs, if you have difficulty memorizing where each of these valves are located, just imagine the location of the heart here. So what happens with the aorta is that it will initially ascend and then later on will descend into the abdomen. So therefore the aortic murmurs like aortic stenosis and aortic regurgitation are best heard in the right upper sternal border versus the pulmonic valves, which are best heard in the left sternal border, left upper sternal border. Now here we have the right atrium, right ventricle, left atrium, and then left ventricle. So the tricuspid heart murmurs are best heard in the left lower sternal border, which is shown right here in a green circle, and then the mitral heart sounds like mitral stenosis or mitral regurgitation are best heard at the apex of the heart, which is located between the left atrium and the left ventricle. And then finally, with the atrial septal defects, since it's between the right atrium and the left atrium, it's best heard in the left upper sternal border versus the ventricular septal defects, which is between the right ventricle and left ventricle, and thus it's best heard in the left lower sternal border. So I would like to repeat, atrial septal defects is in the left upper sternal border, while the ventricular septal defect is best heard in the left lower sternal border. Now, as for the type of the diastolic or systolic murmurs that we are dealing with, here I've provided you with a memory aid to know which murmurs are diastolic and which murmurs are systolic. So all you will have to memorize is arms and parts. So aortic regurgitation, mitral stenosis, pulmonary regurgitation, as well as tricuspid stenosis, all of these are diastolic heart murmurs. And then with the systolic heart murmurs, all you will have to do is to swap R with S. So aortic stenosis, mitral regurgitation, pulmonary stenosis, as well as tricuspid regurgitation, these are the ones that are systolic heart murmurs. So with the diastolic heart murmurs, aortic regurgitation, mitral stenosis, pulmonary regurgitation, tricuspid stenosis, these are all diastolic versus systolic, for which you will have to swap S and R position. So that's one important memory aid that you will have to be familiar with. And then with the location of different heart murmurs, then that's really easy to pinpoint the type of murmurs we are dealing with. Now with the normal heart sound, there are two different components. One is the S1 heart sound, which corresponds to the closure of the mitral as well as the tricuspid heart valves. So this would correspond to the S1 murmur. So S1 murmur is composed of the tricuspid and mitral valve closure, while S2 heart sound is associated with the closure of the aortic and pulmonic heart valves. Now, given that S2 is made of aortic and pulmonic, sometimes it's referred to as A2 for its aortic component and P2 for its pulmonic component. During expiration, the A2 and P2 are so close to each other that you cannot distinguish them. However, during inspiration, since there is more blood that will go to the right side of the heart, it takes longer for the P2 valve to close, and that's the timing between the A2 and P2 increase, and that's the time that you will hear this splitting sound, and this is referred to as normal splitting. So here, normal splitting, pulmonary valve closes later than the aortic valve during inspiration, and that's the time you will hear the normal splitting. So during the expiration, A2 and P2 are so close to each other that you cannot distinguish them from each other, and thus all you will hear is a sound of the S2 heart sound. However, when the patient inspires, then the distance between the P2 and A2 increases, as a consequence of which now you can hear the splitting phenomenon. Now, what happens if there is pulmonary stenosis? At that point, it takes longer for the pulmonary valve to close because there is too much pressure behind the valve, and so therefore the distance between the A2 and P2 increase, particularly during inspiration. So compared to the normal heart valve, you can see that there is a wide distance between the A2 and P2, and this is referred to as wide splitting. So wide splitting is seen with the pulmonary stenosis as well as right bundle branch block. So what happens with the right bundle branch block is that there is delayed activation of the right ventricle, as a consequence of which there is a delayed ejection from the right ventricle, and so therefore again it takes longer for the P2 valve to close, and thus it's associated with wide splitting. A similar phenomenon applies to the aortic stenosis, where at this point now it takes longer for the aortic valve to close because there is too much pressure behind it. Same with the left bundle branch block. Since there is problem with the ejection from the left ventricle, therefore it takes longer for the aortic valve to close. So unlike the normal heart sounds where A2 is heard before P2, with the aortic stenosis or left bundle branch block, you will hear P2 before A2. And so during inspiration, the distance between the two will get closer to each other. So this is kind of paradoxical because we expect normally for the distance between A2 and P2 to increase during inspiration, not to decrease. So therefore, with the aortic stenosis and left bundle branch block, since the distance between the A2 and P2 decrease during inspiration, this is referred to as paradoxical splitting. And then finally, we have the fixed splitting, which is seen with the atrial septal defect. So during inspiration, since there is atrial septal defect, the pressure in the right atrium and the left atrium will be equal, and thus therefore there won't be any increase in the distance between the A2 and the P2, and this is referred to as fixed splitting, which is seen with the ASD or atrial septal defect. Now back to the table here. So we've just discussed the S1 and S2 heart sound and different anatomical defects that are associated with abnormal forms of splitting. Next, I would like to go through different heart murmurs and provide you with an example. So here is an example of a normal heart sound. And as you can see, it's like lopped up, S1, S2, S1, S2. S3 and S4 heart sounds are best heard in the apex of the heart at the left decubitus position. S4 heart sound is associated with hypertrophic cardiomyopathy, while S3 is associated with dilated cardiomyopathy. Now with the S4, it's a pre-systolic gallop, so S4 is heard before S1. And here is an example of a S4 heart sound. So you can see from this heart sound that it was like do-doom doom, do-doom doom, do-doom doom. So it's a pre-systolic heart gallop, do-doom doom, do-doom doom, versus the S3 where you will hear doom do-doom, doom do-doom, doom do-doom, because the heart murmur is after the S2. So here is an example of the S3 heart sound. Next, we have the aortic stenosis as well as aortic regurgitation. Now, with Both of these conditions, you will hear them best in the right upper sternal border, as I just discussed earlier with you. With the aortic stenosis, it's usually seen with the elderly patients that develop aortic stenosis, and they develop syncope with exertion. So that you may find that information in the stem of the question to help you with the diagnosis of this type of murmur. And so it's associated with an ejection click followed by a crescendo, decrescendo murmur. And so this type of murmur radiates to the carotids. So it's important for you to know that the aortic murmur radiates to the carotids, while the mitral regurgitation radiates to the axilla. Now, two important phenomena that is associated with aortic stenosis include pulsus parvus et tarda, where there is a weak pulses as well as delayed peak because of the problem with the ejection of the blood from the left ventricle. And then there is also paradoxical splitting, as we just discussed earlier. So left bundle branch block as well as the aortic stenosis, these conditions are associated with paradoxical splitting because instead of increasing the distance between A2 and P2 with inspiration, there would actually be a decrease in their distance, and so therefore it's referred to as paradoxical splitting. And so here is an example of the heart murmur for the aortic stenosis. Next, we have the aortic regurgitation, which is associated with the diastolic decrescendo murmur. So here we have the S2, and after S2, we have the heart sound. So it's a diastolic murmur that is associated with a wide pulse. Now, the reason aortic regurgitation is associated with a wide pulse is that there is a backflow of blood into the left ventricle during relaxation, as a consequence of which there would be an increase in the systolic blood pressure. So, for instance, you will see an example of systolic blood pressure of 170, and so because there is too much systolic blood pressure, there would be a reflex dilation of the peripheral vessels, and so therefore there would be a significant drop in the diastolic blood pressure. So the pressure would be something like 170 systolic over 60 diastolic, and so that is why it's referred to as having a wide pulse pressure. Other findings that you will see with the aortic regurgitation, for instance, include head bobbing as well as the water hammer pulse. Next, we have the atrial septal defect, which, as I just discussed earlier, is best heard in the pulmonic area, which is located in the left upper sternal border. And atrial septal defect is characterized as an ejection systolic murmur with fixed split S2. So here, as I just discussed earlier, the atrial septal defect has a fixed splitting, meaning that during expiration and inspiration, the distance between the A2 and P2 is fixed. And so here is an example of an ASD heart murmur. And then with the ventricular septal defect, I didn't list it here, but it's a holosystolic murmur that is best heard in the left lower sternal border, so at the tricuspid area. And so again, let me remind you that if here was the heart, we had the right atrium, right ventricle, left ventricle. So the ventricular septal defect is best heard in the left lower sternal border, while the atrial septal defect is best heard in the left upper sternal border. Next, we have the tricuspid regurgitation, which is a holosystolic murmur that is louder during inspiration. And this is due to the fact that during inspiration, there is more blood that goes to the right side of the heart. Therefore, the tricuspid as well as the pulmonic heart sounds would be louder during inspiration. So in the example that I'm going to provide you here, just note how the murmur is louder during inspiration compared to expiration. Next, we have the mitral stenosis, which has an opening snap followed by a late diastolic murmur. Now, this condition is usually associated with a type of infection. And could you tell me what type of infection can increase the risk of developing mitral stenosis? And the answer is rheumatic fever. So rheumatic fever increases the risk of developing the mitral stenosis. So the other question I would like to ask you is that what type of bacteria is associated with the development of the rheumatic fever? And the answer is group A streptococcus. So infection with group A streptococcus, if the patients are not treated, therefore they can develop mitral stenosis, which presents with the opening snap followed by a late diastolic murmur. Now, because of the mitral stenosis, there would be too much pressure on the left atrium, as a consequence of which these patients can develop left atrial dilation. And left atrium is the most posterior structure of the heart, which can compress the esophagus as well as the recurrent laryngeal nerve. And thus, patients with mitral stenosis can develop dysphagia as well as the hoarseness of their voice. And so here is an example of a heart sound for the mitral stenosis. Next, we have the mitral valve prolapse that is usually associated with mitral regurgitation, and this type of murmur is associated with the mid-systolic click followed by a late crescendo murmur. And so clinical features of mitral valve prolapse include pain, palpitations, as well as panic attack. And so the memory aid that I have for you is that mitral valve prolapse is associated with pain, palpitations, as well as panic attack. And so here is an example of a mitral valve prolapse associated with mitral regurgitation. Alright, now that we are done with the discussion of different heart murmurs, next I would like to go over the expected blood pressure in different chambers of the heart. And the reason it's important for you to know the expected blood pressure is that if there is a defect in the heart, there would be distortion of the normal blood pressure. And so on the exam, you may be provided with different blood pressures and ask you what kind of structural defect is present in this patient. So in order to answer those questions, you will need to know the normal blood pressure in different heart chambers. And so for memorization, I've provided you with a memory aid that makes it really easy. So here we have a nickel in the right atrium, we have a quarter inside the right ventricle, we have a dime in the left atrium, and then finally we have a dollar in the left ventricle. Now, given that we have a nickel in the right atrium, the pressure in the right atrium is 0 to 5. So 5 for nickel. With the right ventricle, it's right after the right atrium, which was the nickel, and contains a quarter. So the pressure in the right ventricle is between 5 to 25. So 5 for the nickel that was earlier and 25 for the quarter that it contains. With the pulmonary artery, it's located between the right ventricle and the left atrium. So the right ventricle was 25, left atrium is 10. So the pressure in the pulmonary artery is 10 for dime and 25 for quarter. And then with the left atrium, the blood pressure is 5 to 10. So 10 is for the dime. And then finally for the left atrium, it's right after the dime, which is 10, and it contains a dollar, which is 100 cents. So 10 to 100 is the expected blood pressure in the left ventricle. Now on the exam, you may be provided, for instance, with a blood pressure of, let's say, blood pressure of 4/10, and ask you what type of defect is seen with this patient. So what can happen is that there could be, for instance, stenosis of the tricuspid valve, or there could be, for instance, atrial septal defect, which causes the left atrium and the right atrium to have similar pressures. Or then another example that you may be provided is that, let's say with the right ventricle, they give you that the blood pressure is 8/70, and ask you what type of heart defect is seen with this patient. So with the right ventricle, it could be pulmonary stenosis that causes increased blood pressure in the right ventricle. It could also be pulmonary regurgitation. Another example that you may be provided is that this blood pressure is decreased. Let's say we will have like 8 and 75. And so with this condition, then it's a ventricular septal defect that makes the blood pressure in the left ventricle and the right ventricle very similar to each other. And that concludes our discussion of different heart murmurs, different types of splitting, as well as the expected blood pressure in different chambers of the heart.